Hello students, I'm coming to you with the next video lecture on Rubin and Babi, chapter 13. Let's go ahead and get started. So we're continuing on in Unit 4, which is related to designs for evaluating programs in practice. We've already covered chapter 11 and 12, and now we are moving into chapter 13, which is related to single case designs. We are also continuing on in phase 3 of the social work research process, which is related to choosing research designs and data collection methods. In addition, we are also continuing to talk about this difference between group and individual research designs. And we know that experimental and quasi-experimental designs are most appropriate for groups of clients. And so in this video, we will now learn that single case designs are most appropriate for individual clients. And so we're continuing as well to look at this relationship between research design, inference, and causal inference. And we already know that experimental and quasi-experimental designs are appropriate for drawing causal inferences. And so in addition, we will also add on to our knowledge base of research designs the idea that single case designs are also appropriate for drawing causal inferences as well. Before we move into the specifics of single case designs, I thought it was appropriate to talk about the difference between time series designs and single case designs, given that there are a number of similarities between these designs, but there are also some differences that I think you should be aware of as well. So in chapter 12, we saw that when randomization or the use of a control group is not possible, that time series designs can also help us to evaluate the impact of an intervention on client outcomes. And like time series designs, single case designs also involve taking repeated measures of the dependent variable in order to identify trends in the target problem of interest. However, there are some distinctions between the designs that I think, that I think you should be aware of. So one of the most important distinctions is sample size. So when we think about the single case design, it is just what the title suggests. It focuses on a single case or a single client. And so our sample size in a single case design is always 1. And so the trends in the dependent variable that we're looking at in a single case design are always going to be based on individual case data. And by contrast, in a time series design, because we know that these designs are most appropriate for groups of clients, the N or the sample size will always be greater than 1. And so in turn, the trends in the dependent variable that we're looking at in a time series design are always going to be based on aggregated group data. So I thought here it was also important to talk about the difference between aggregated group data and individual case data. So in the time series design, again, we're dealing with aggregated group data. So essentially what we're doing is we're collecting data from multiple clients within the group, and we're compiling that data into one summary number. And in the individual in single systems designs, when we're dealing with individual case data, well, there's no need to aggregate data because we're only dealing with one case. Okay, so these are the major differences here. So we'll take a look on the next slide at what it looks like, or when we go to plot this data on our trend line, what this will look like and what each point on the trend line represents. But again, keeping in mind that aggregated data is utilized in the time series design, and that aggregated data represents multiple clients in one data point, versus in the individual case data, which is used in the single case design, each data point represents the individual client. And so here's what a trend line might look like, whether it be for a time series design or for a single case design. But the question becomes what each data point represents. So again, here we know that we're always in either design taking repeated measures of the dependent variable. And each time that we take a measure of the dependent variable, we're plotting that data onto our graph in order to observe the trend. And so here, each data point, if we're talking about a time series design, each data point represents the aggregated group data. Okay, that's what each data point represents. It represents an aggregation of the group's data as a whole. And for the single system design, each data point here would represent the individual client. Okay, so we use the same kind of mechanism for identifying trends, whether we're talking about a single case design or a time series design. But just keep in mind that the only difference here is what each data point represents. Okay, so whether it represents the group's aggregated data or whether it represents the individual client data. Okay, so just keep that in mind. Here's our case study, once again, that we've been drawing on in each of our videos. And I put this before you again, just so that you keep in mind and know that we're continuing to draw on this same case. And I hope that by now you have realized that no matter the design that we've talked about, we've always been able to draw from the same case in terms of applying this case to the various different designs that we are discussing in this unit. And so we'll continue to do that in looking at how we can take one case scenario and apply that same scenario to multiple types of designs. And so a couple of key concepts that are important to understand as we talk about single case designs. One is called multiple measurement points or repeated measures. And I've already kind of alluded to this, but I will reiterate and go into greater detail here. So multiple measurement points are repeated observations of the dependent variable over time. And having numerous measurement points are beneficial in a number of ways for both the researcher and the clinician. The one thing that multiple measurement points allows us to do is to detect trends in the dependent variable. It also allows us to determine whether changes in the dependent variable can be attributed to changes in the independent variable or to some other alternative explanation. And it also allows us to pinpoint precisely where the change in the dependent variable occurs and whether those points coincide with changes in the independent variable. So here are a couple of examples here. And so that kind of help to show why having multiple measurement points or repeated measures are so important for being able to identify trends in the dependent variable. So we see here that we have a baseline. We start by establishing a baseline. And then we see that after the introduction of the intervention, this line here represents the intervention. After the introduction of the intervention, then we see a very clear downward trend during the intervention phase. And so we'll talk about the differences between the baseline and the intervention phase as I get more specific in the discussion about single case designs. But essentially, this demonstrates the idea of multiple measurement points in that it allows us to see or to detect trends in the dependent variable. And it also allows us to see whether a shift occurs in the dependent variable after the introduction of the intervention. And that's ideally what we want. This graph supports effectiveness of the intervention simply because we can clearly see here, given the trend line, that there was a decrease in the intervention, in the trend in the dependent variable following the introduction of the intervention. And that's ideally what we want. We want to be able to clearly see a pattern of either an increase or a decrease or whatever it is, depending on how we operationally define our target problem, whether it be an increase or a decrease in the trend. We want to be able to see a clear trend that supports the effectiveness of the intervention in our various data points that we plot on our graph. And then we see here in this graph to the right that this particular graph doesn't necessarily support the effectiveness of the intervention simply because we see here that in the baseline, we see a particular downward trend, and the same downward trend continues even after the introduction of the intervention. So there is no shift either in increasing or decreasing trend. We see the very similar trend in the baseline as we do even following the introduction of the intervention. So this trend line here doesn't really suggest that the intervention is effective because we don't really see much of a change in the trend line, right? So this is what we're looking for, and this is what collecting multiple measurement points or repeated measures allows us to do. And then we have the concept of unlikely coincidences. And this particular concept essentially means that, or it talks about the extent to which changes in the dependent variable consistently occur after the independent variable or intervention is introduced or withdrawn, and not at other times. So we're really looking to see, when we're analyzing our trend line, what we want to see is a clear indication that there's a change in the dependent variable only after the intervention has been introduced, right? And we want to see that trend line in the direction that we would expect, right? So if we're looking at depression, well, we want depression to decrease ideally as a result of whatever the intervention is that we are introducing with our client. And so we want to see in that case a downward trend, right? But if we're looking at a student and we're looking at issues of academic achievement, well, whatever the intervention, if it's tutoring or mentoring or whatever it is, ideally we want to be able to see an increase in the trend line, right? So it really depends what the trend line looks like after the introduction of the intervention really depends on what the target problem is that we're measuring. And we want it, but either way, we want that trend line to go in the direction that we would expect in order to indicate effectiveness of the intervention. And the more that we are able to show that there's this clear increase or decrease in the trend line after the intervention, the more we can show that, the more we can rule out unlikely coincidences or alternative explanations. And so here again, as I just showed a couple of slides ago, we see this graph here that gets at this idea of unlikely coincidences, because we see that we have our baseline here, and then it's only after the introduction of the intervention that we see this downward spiral in the trend line. Okay, so when we see things like this, then it helps us to rule out other alternative explanations that could be interfering with the introduction of the intervention. In terms of the basic logic of the single case design, single systems or single case designs apply the logic of time series designs to evaluate the effect of an intervention on individual cases. Okay, so a single system design, in other words, is essentially the same thing as a time series design, except the focus is on individual cases rather than groups of cases. The design involves obtaining repeated measures of a client system with regard to an outcome or target problem. And repeated measures are obtained before the intervention is introduced, which we call the baseline phase, and then after the intervention is introduced, which we call the intervention phase. The goal is to determine if a sustained pattern of improvement in the target problem begins shortly after the onset of the intervention and not before, right? So this is what I just mentioned previously, is that we're always looking to see a sustained pattern of improvement, whether it's an increasing trend or a decreasing trend, whatever it is, we want to see a sustained pattern of improvement in our target problem only after the onset of the intervention. And so we see here in this example, our dependent variable is here on this axis here, and we see that our dependent variable is the percentage of on-task behavior. And then let's just say hypothetically that our independent variable or our intervention is behavioral reinforcement therapy. So we see here that at the baseline, we have a very low percentage of on-task behavior. And then we have the introduction of our intervention, which is represented by this dotted line here. And then we see only after the introduction of the intervention, we see this increasing trend line in on-task behavior. So that's essentially what we want to see here, is after the introduction of the intervention that there's a clear and sustained trend in our dependent variable. When the logic of time series is applied to the evaluation of outcomes with individual clients, The research design is referred to as a single subject, single case, or single system design. So these terms can be utilized interchangeably. So essentially, whenever we apply the logic of a time series design to a single client, then we can refer to this design as single subject, single case, or single system design. And again, as I mentioned before, a distinguishing feature of the design is that it has a sample size of 1. But because this particular design has a sample size of 1, consequently, this means that a chief limitation of this design is that it has a limited external validity or generalizability due to the small sample size and lack of representativeness. If we're only talking about one client, then it's difficult to generalize whatever we find from that one client to other clients. However, where we can strengthen our external validity and generalizability is through replication. So the more that we're able to replicate a single system design with multiple clients, the stronger our evidence base becomes, and the stronger our ability is to or the stronger our external validity and generalizability becomes as well. So single systems designs can be very useful for practice, in which you may not necessarily be seeking to generalize or publish your results in practice, but in the event that you would like to publish your results, it really is about replicating, right? And being able to build the knowledge base for a particular single systems design. So through replication, we're able to strengthen our external validity. So in terms of the anatomy of a single case design, so as I just mentioned or alluded to, in a single case design, we always have, or not always, I shouldn't say always, there are some designs that don't have a baseline, and we'll talk about that momentarily. But in our very basic single case design, we have a baseline phase, or what we call phase A. This is the phase of the repeated measures that occurs before the intervention is introduced. So the data points that we collect, or the repeated measures that we collect prior to the introduction of the intervention, is called the baseline. The baseline is the control phase, and it serves the same function that a control group does in group experiments, or for example, a quasi-experiment or a true experiment. And then we have our phase B, or our intervention phase. And this is the phase of repeated measures that occurs after the intervention is introduced. Causal inferences are made based on shifts in the trend or pattern of the data from the A phase to the B phase. The patterns in the data collected during the baseline phase are compared to patterns in the data collected during the intervention phase. So this is the reason why we say that the baseline serves as the control, or a way of comparing, right? So the baseline is a control, as the control phase is compared to the patterns of the data that we find in the intervention phase. To infer that an intervention is effective, we look for shifts in the trend or pattern of the data that occur between baseline and intervention phases. Establishing a stable trend during the baseline phase is very important to the internal validity of single case designs. So essentially, we really need to have a very stable trend during the baseline in order to really be able to determine whether the intervention, what's happening in the intervention phase. So because we're always comparing the baseline phase to the intervention phase. So we really want to have a very clear or stable baseline prior to introducing the intervention, so that we're able to make a clear determination or analysis of what's happening or what's going on in our intervention phase. So in terms of the baseline phase, internal validity is enhanced when the baseline has enough measurement points to show a stable trend in the target problem. So even though there's no specific number of measurement points per se, your text suggests to plan for about 5 to 10 baseline measures. The more data points we have, the more confidence we can have in the stability of our baseline. Trends are identified by plotting the data points on a graph and drawing a line between each point and then observing the trend. The meaning of the trend, as I mentioned before, the meaning of the trend really depends on the operational definition of our target problem. So as I mentioned, we want to be able to see a decreasing trend in depression. That would indicate improvement. If it's academic achievement, we would want to see an increasing trend in like grades or attendance or whatever it is that we're measuring with regard to achievement. So it really depends on how we operationally define our target problem in terms of the trend that we're looking for. But having at least 5 to 10 data points in our baseline helps us to establish a good, clear baseline prior to introduction of the intervention. And so here are some examples of baseline trends. So here would be, this is what a clear increasing trend would look like, and then a decreasing trend, a flat trend, a cyclical trend, and an unstable trend. So we definitely don't want something like this going on, right? So a lot of times it's very important to talk to our clients as we are establishing our baseline, or even before we go about establishing our baseline. It's very important to talk to our clients about what's happening in their environment at the time, so that we can kind of gauge when we begin to take these repeated measures, how stable of a trend line will we be able to achieve. If the client is going through a very tumultuous time in their lives and they have a lot of things going on and a lot of things on their plate, well, our trend line at the baseline could end up looking something like this. Right? So if we don't talk to our clients and we're not in communication with our clients about what's going on with them, then we might get we might end up producing a baseline that is very hard to interpret. And so we want to be in conversation with them so that we can try to establish as clear and as stable of a baseline as possible. And so here we have a very clear baseline, and then we have our introduction of the intervention, and then a very clear trend post introduction of the intervention. So this is ideally what we want. And then here we have yet another example of what a very unstable baseline could look like. But even still, after the introduction of the intervention, we still have a very clear trend line in the intervention phase that suggests some success, a successful outcome with the intervention. So sometimes it can be very difficult to establish a clear baseline. It's not always possible to do that. It depends on our circumstances. It can be very difficult. I don't want to underestimate how difficult it can be as a practitioner to collect repeated measures. And your text talks a lot about that in terms of the feasibility of being able to collect repeated measures from clients. There are a lot of obstacles around that, and it's not impossible to do, but it's not an easy thing to do either. And so it could be quite possible that we end up getting a baseline that looks like this, right? But it's not impossible post the intervention to get a clear trend that indicates effectiveness. But it's just important to understand how the importance of having a stable baseline, if at all possible, if it is at all possible to be in communication with our clients about what's happening, so that when we begin to collect repeated measures at the baseline, that we do so having some information about what's going on and make the best attempt that we can to establish the most clear, the clearest baseline that we possibly can. And also your text talks about the possibility of, or the option rather, of establishing a retrospective or reconstructed baseline. And this is based on the notion that, as I just mentioned, it may not always be possible to collect repeated measures from a client. For some reason, they may not be willing or able to engage in the process of repeated measurement. And so in this case, we also have the option of constructing a retrospective baseline. And this retrospective baseline is constructed based on past data. And the two primary sources of past data are available records or client memory. And your text talks about how when we have to rely on client memory, it does give some very helpful guidelines. And it suggests that we use identifiable events that are easy to recall, and that we use only the immediate past, such as the past week or two. So your text suggests not going back any further than a month, just because we know the issue with being able to recall anything that happened more than a month ago. So it is possible to establish a baseline, a retrospective baseline that is based on previous data, but just keeping in mind what some stipulations are around that. So this is another thing that we can think about, and it's always good to know what your options are and what your alternatives are, given the realities of practice. And there are times in which we may not necessarily be able to adhere strictly to some of the requirements of each design. So it's always good to know what the alternatives are and what sort of the workarounds might be to some of these designs. So this is one thing to keep in mind in terms of another way to go about doing this. In terms of types of single case designs, we're going to get into that next, because your text talks about several different types of single case designs that you should be aware of as well. So in terms of types of single case designs, we have the AB, which is the most basic single case design. And then we have the ABAB, and then we have multiple baseline designs, multiple component designs, and B plus designs. So within the AB design, again, this is the most basic single case design. This design includes one baseline phase and one intervention phase. This design is popular among practitioner researchers because it is more feasible and allows for more immediate feedback, and it poses less conflict with service delivery priorities. And the reason for this is because it has one baseline phase and one intervention phase. And it still has the multiple measurement points within each phase, but it only includes just one baseline and one intervention phase. And so this allows for more immediate feedback, and it poses less conflict with some of the service delivery priorities that may be present within our various agency contexts. However, it is weaker than single case designs with more baselines, because the more that we're able to the more baselines and intervention phases that we're able to include, the more we're able to provide concrete evidence that it is indeed the intervention that caused the outcome and not some other alternative explanation. So essentially including multiple baselines and multiple intervention phases allows us to replicate what it is that we're finding over and over again, and it just provides more credible and stronger evidence that shows that it was only after the introduction of the intervention that we were able to see this change in the dependent variable. So the more that we're able to show that through having multiple baselines and multiple intervention phases, the more credible and reliable our results are. And extraneous events are controlled better when there are several shifts between the baseline and intervention phases, as I just mentioned. So the more that we're able to show these consistent trends, the more we're able to rule out extraneous events. Because keeping in mind, just like when we talked about experimental and quasi-experimental designs, the researcher's goal is always to show that it is indeed the intervention that caused the outcome, and not some other alternative explanation or extraneous event. And so by having multiple baselines and multiple intervention phases, we're able to show this over and over and over again, that each time after the intervention was introduced, that we see this change in the dependent variable. And so this is just an example of how we can go about applying this to our case scenario that we've been talking about all semester long. So we see here that if we wanted to apply this AB design to our case scenario, what we could do with an individual client is we could, in our baseline phase, we could measure parenting self-efficacy, depression, and perceived social support. And then we can introduce the individual therapy and mentoring. And then we can also then go into our phase B, which will be our intervention phase, and we can collect multiple data points there as well, or take multiple measurement points in our phase B as well on each of these outcomes. And so this is just an example of how we can utilize a single case A/B design and apply this design to the same case scenario. And here would be our multiple measurement points. Okay, so this would be our single case A/B design. And so here we could take multiple measurement points. We have 5 points at the baseline and 5 measurement points during the intervention phase. And then here's our next design, the AB/AB design. And so to better control for extraneous events, the AB/AB withdrawal or reversal design adds a second baseline and a second intervention phase. The second baseline is established by withdrawing the intervention for a while. After a stable trend is identified in the second baseline, then we reintroduce the intervention. So essentially here we see that we have our first baseline here, and then we introduce our intervention, and then we see that we observe the trend during our intervention phase. Here is where we withdraw the intervention, and we withdraw the intervention for a while here, and then after we've withdrawn it for a while, then we establish a new baseline, and then we're able to reintroduce the intervention in this phase here. Okay, so we see each time, and the reason why this is a stronger design is, as I mentioned before, each time we want to be able to show that each time that we establish a baseline and introduce the intervention, withdraw, reestablish the baseline, and introduce the intervention once again, we see each time where we see clear shifts in the dependent variable each time. And so the more that we're able to demonstrate this shift or this change in the dependent variable after the introduction of the intervention, the more we can more definitively say that it was in fact the intervention that caused the change in the dependent variable and not some other alternative explanation. So again, I'll just explain just for clarity what's happening here in this graph. So we are establishing our baseline here in this first phase. We're introducing the intervention here. We're collecting additional measurement or data points here during this first intervention phase. Here is where we withdraw. Okay, and your text doesn't really say how long the withdrawal period should be, but here's where we withdraw the intervention, whether it be for a week, 2 weeks, however long it might be. That would be something you would have to assess based on your individual client circumstance. But this point here is where we withdraw the intervention for a certain time period, and then we reestablish a new baseline, and then we reintroduce the intervention again here. Okay, so if the intervention, so the assumption underlying this design is that if the intervention caused the improvement in the target problem during the first intervention period, then the target problem will reverse back toward its original baseline after the intervention is withdrawn. And when the intervention is reintroduced, then the target problem will improve again. So the assumption here is that when we withdraw this intervention at this point, that the baseline will reverse back to whatever it originally was, right? So that's the assumption, is that if the intervention is working, if you take it away from the client, if you withdraw it from the client, then the baseline should change, right? So it should look differently as a result of the intervention being withdrawn. It should reverse back to what it was initially, and then when we reintroduce the intervention here in the second phase, then we should see yet another change in the expected direction for the dependent variable. So that's essentially the underlying logic and assumption of the AB/AB withdrawal or reversal design. And then here next we have the multiple baseline design. So for multiple baseline design, we begin with 2 or more baselines simultaneously. And these 2 or more baselines could be one client with different target behaviors, or it can be multiple clients with the same target behavior. In this particular graph, this is multiple clients with the same target behavior. So because we see here resident 1, resident 2, resident 3. So these are multiple clients here, but we're measuring the same target behavior for each client. But the unique thing about this design is that although each baseline starts simultaneously, so we're starting the baseline at the same time for every client, but the intervention phase is introduced at different points, right? So we see here that the baseline here for this first client is pretty short, right? So we see, let's see, the observation points are days. So we see that that for this first baseline, the first client's baseline lasts about 4 days, right? So after 4 days, we introduce the intervention, and then we begin our repeated measures during the intervention phase. However, for the second client, we see that the baseline period is a little longer, right? So about 8 days, right? And then we introduce the intervention, and then we begin to collect our repeated measures during the intervention phase. And then yet for the third client, we see that their baseline is even a little longer, right? So we see that the baseline here for this client is 10 days before the intervention is actually introduced. So this is the reason why we call this a multiple baseline design, is that although each baseline starts simultaneously, the intervention phase begins at a different point in time for each client. So the assumption underlying this design is that if the intervention is accountable for improvement in target behaviors, that improvement will occur on each graph at a different point that corresponds to the introduction of the intervention. So in other words, even though the baseline is different, right, for each client, the improvement in the intervention is going to correspond to the baseline, right? So the improvement, if the intervention is working, the improvement will begin only after the introduction of the intervention, no matter when the baseline begins, right? So it doesn't matter when we start the baseline. If the intervention is effective and working, the effectiveness of that intervention is only going to kick in once we introduce the intervention. So we're going to see improvement or change in the trend line only after the intervention is introduced, regardless of when it's introduced, right? So that's the underlying assumption with this particular design. For the multiple component design, this design allows for practitioners to monitor baseline trends and client progress and to introduce several interventions throughout the course of treatment. Interventions that show little to no evidence of effectiveness are replaced with others that may be more promising. This design also allows for introducing interventions in different sequences with the same or with different clients. So in other words, we see here that we have a baseline, and then throughout the course of the intervention, we're introducing different interventions throughout the course of treatment. And we're able to make modifications or make changes to the interventions that we're introducing our clients to, because, for example, if we find that perhaps social skills training is not working, then maybe we can try something like case advocacy, right? So this kind of design allows for introducing several types of interventions throughout the course of treatment. And it also allows for us to change up the sequencing, right? So we might do more of an ABCD combination for one client, but then we might do maybe more of an ACDB kind of combination for a different client. So this particular design allows for us to look at interventions and the multiple components of an intervention simultaneously. And then finally, we have the B and the B+ design. So this design is useful if you are unable to establish a sufficient baseline, but you still need to monitor client progress. So a graph that only has a B phase is referred to as a B design. So for example here, this would be a B design. So we don't see a baseline phase here at all. We only see just a B phase, so just an intervention phase. So once we've introduced the intervention, then we begin to collect our multiple measurement points after the intervention has been introduced. And there are instances in practice in which you may not necessarily be able to establish a baseline. It is ideal, right? Because we know that our baseline is our control phase, right? So we're always, and it's the phase by which we compare our intervention phase. So we're always ideally comparing our baseline phase to our intervention phase. But the realities of practice are such that you may not necessarily be able to establish a baseline. And so in that particular case, these B and B plus designs can be useful, right? So in this particular design, it's just after following the intervention phase, we're able to collect some repeated measures during the after the introduction of the intervention. So that would be a B design. And then a graph that has only a few pre-intervention or baseline points that won't necessarily suffice for a baseline, but are still included. This will be a B plus design, right? So here, let's just say that you were only able to collect maybe 2 or 3 data points prior to the introduction of the intervention. Well, this wouldn't necessarily suffice for a stable and clear baseline, right? So we can't necessarily form a baseline with only 2 or 3 data points, but we may still need to or want to include those data points anyway, right? And so this wouldn't quite be a B design, but it wouldn't quite be an AB or AB design either, right? But it still has at least 1 or 2 or even 3 data points at the baseline. So we would call this a B plus design. Because again, it's not quite an A-B design and it's not quite an A-B design, but we still have a couple of data points here at the baseline. So if your plot looked something like this, then this will be more of a B plus kind of design. And so these kinds of designs, again, can be useful for practice. Again, as I mentioned, it's always good to have alternatives. It's always good to know what your workarounds might be if you are in a position where you can't necessarily fully carry out the design, but you still want to be systematic and methodological in your approach to monitoring client progress. And so here it's important to note that because we don't have a clear baseline phase, we can't necessarily draw any causal inferences from these designs, but again, they can still be useful. So now let's talk a little bit about some measurement issues because we know that we're taking repeated measures, right? So we're not just taking one measure pre-intervention and one measure post-intervention. When we're taking repeated measures over time, it is really, really important that we understand some things about some of the measurement issues that can arise along the way, simply because, again, these are designs in which repeated measures are taken. So we have to be very cautious about how we go about measuring our dependent variable. So a couple of things that I want to talk about with regard to measurement issues are first, how we go about operationally defining target problems and goals. Also how we go about developing a measurement and data collection plan, and then also issues of triangulation. So early decisions in planning a single case experiment involve establishing a contract in which the client and practitioner agree on the problems to be tackled and how they will be monitored, and also defining the target problems and goals in precise and observable terms. These decisions influence the next phase of the research plan, which involves developing a measurement and data collection plan. So in other words, once we have developed a contract with our client in terms of what the problem of focus will be and how the problem will be tackled and monitored, then we want to move on to defining the target problem and goals in precise and observable terms so that we know how to go about measuring the target problem. There are 3 things that we need to think about with regard to developing a measurement and data collection plan, and these things are what to measure, who should measure, and with what measurement instrument. So in terms of what to measure, the choice of what to measure requires that you translate the target problem into something that is observable, that is feasible to measure repeatedly, keeping in mind that we're taking repeated measures. and that occurs frequently enough to be measured on a regular basis. So, for example, if the target problem is depression, then you will need to translate the construct of depression into observable indicators and come up with a feasible way to monitor fluctuations in depression from week to week, day to day, month to month, whatever the time frame, over the course of treatment. So, for example, here might be one way that we might translate the target problem of depression into a measurement tool. And so here, this is called an individualized daily rating scale for depressed mood. So if we wanted to track client progress on depressed mood daily, then we might ask our client to complete something like this, an individualized daily rating scale, where they could record the date and then record their average level of depression for each day. Okay, so this might be one way of measuring depressed mood on a daily basis. But again, this could be month to month, week to week, right? So we could also change this to average level of depression for the month or average level of depression for the week, right? So we can change the time frame. But at any rate, this is one way of operationalizing depressed mood. In terms of who should measure, there are 4 options regarding who should do the measuring or who the sources of data should be. Each of these options has its advantages and disadvantages, and you can use each of the approaches alone, or it's best to really combine the approaches using a method of or principle of triangulation. And we'll talk a little bit about triangulation momentarily. The best choice will vary according to the client and practitioner circumstances. And so here are the sources. Again, it's either yourself as the practitioner, the client, a significant other, or available records. And so here I've laid out the advantages and disadvantages of each one here so that you're able to see. And I'll just go through a couple of these and then you can read these on your own as well. But if you are the source of data or you are doing the data collection, well, the advantage is that there would be more accuracy in scoring the actual measurement tool because you as the practitioner would know how to score the tool, right? However, the disadvantage would be time, right? The time involved in keeping track of client outcomes. And then it's also, there are only certain things that only the client can record. For example, the number of hours of sleep per night, right? So we have no way as the practitioner of recording number of hours of sleep. That's something that a client would have to record. And then it's more obtrusive if we do the observation ourselves as well. And then in terms of client monitoring, well, the advantage is that it's convenient, it's time saving, it allows for gathering the data more rapidly. It also promotes a sense of awareness within the client so that they can self-monitor, right? So that they know where they stand with regard to the particular outcome. It's always good for the client to be aware of themselves. But the disadvantage is that there's less accuracy in scoring because the client may not or will not, more than likely will not be knowledgeable on how the tool is most appropriately scored. They might also lack follow through with completing the measurement tool consistently. So they may not necessarily be consistent and accurate each time they record their data. And in addition, social desirability bias or the desire to please the clinician because the client is aware of what the treatment of what the treatment goals are, they might be more inclined to respond to the measurement tool in a particular way. So we want to be aware of that. And so the other sources of data are significant others as well as available records. And so I'll allow you to review those points yourself. But the most important thing here to realize is when it comes to sources of data, there are advantages and disadvantages to each one. In terms of with what measurement instrument, the types of instruments you choose or construct to collect or record your data will be influenced by your choice of what gets measured and by whom. So, but the overall thing to remember is that there are 3 main measurement instrument options. One is the behavioral recording form, the other is the individualized rating scale, and yet another is a standardized scale. So here's an example of a behavioral recording form, and this form in this particular form, behaviors are recorded by frequency. So we see here where it says frequency recording template. Okay, so and we're asking the client to report on a particular behavior or cognition, and they would write that behavior or cognition here in this line, and then they would write the date for each day and the number of times the behavior or cognition occurred. So this is more of a frequency outcome. Okay, so that's one option. And then here's another behavioral recording form, but this form is based on duration. So this is duration recording template. So we're still asking about behavior or cognition, but for example, number of minutes behavior or cognition lasted. Okay, so this is more of a duration approach to measurement. Okay, so this is another option. And then here again, we have the individualized daily rating scale, and we can change this to whatever target problem or outcome we need it to be. And we can also change the scale as well. So instead of it being from 0 to 7, it could be 0 to 5, it could be 0 to 3, but I recommend at least five data points, right? So five, at least a scale that has ranges from 0 to 5. 0 to 7 might be a little bit too granular and specific. A good happy medium between 3 and 7 is 5. Okay, so at least 5 points on the scale. But we can modify this and change this however we need to. Okay, so this is an individualized daily rating scale. And then finally, we have our standardized scale. So these are the kinds of scales that we would find in measurement construction studies, the kinds of studies that we've been talking about earlier on in the semester. So this is the Center for Epidemiologic Studies Depression Scale. And there are plenty of other scales that are out there, depending on whatever the target problem is that you're trying to measure. But yet another option for measurement is the standardized scale as well. In terms of direct behavioral observation, so if we don't necessarily want to rely on measurement instruments or measurement tools because of issues around self-reporting and social desirability bias and all those kinds of things, we also have the option of directly observing the behavior of our clients. But there are a couple of things that we want to take into consideration about direct behavioral observation that I want to discuss here as well. And so in terms of direct behavioral observation, as I mentioned, rather than relying on people to report on their behaviors using standardized tools or some other kind of tool, we can also observe their behavior directly. If direct behavioral observation is your primary source of data, it is important to use the principle of triangulation, as I mentioned, because client self-monitoring alone can be vulnerable to research reactivity. In other words, whenever clients know that they're being observed, then this could change the nature of their behavior. 3 possible sources of direct behavioral observation could be the client themselves, significant others such as spouses or family members, or the practitioner. And then if we're using direct behavioral observation, we want to make sure, if at all possible, that we assess for inter-rater, inter-observer reliability across observers. So if we ask clients to observe themselves, significant others, as well as practitioners, we want to look at the extent to which the ratings across observers are in agreement. In terms of obtrusive versus unobtrusive observation, unobtrusive observation is where the observer blends into the observational setting in a way that the act of observing is not noticeable to those who are being observed. So it's essentially like being a fly on the wall, right? So those who are being observed are not necessarily very aware. I mean, they know that the observer is there, right? But you try to be as inconspicuous as possible so that you are not as noticeable within the observational setting. And then, of course, the opposite would be obtrusive observation, which is when the subject is aware of the observation. And this increases the risk of research reactivity, which is what I mentioned, or when the subject or the client begins to behave in an atypical manner in order to convey a socially desirable impression. And then in terms of data quantification procedures for direct behavioral observation, data gathered through direct observation can be quantified in terms of frequency, duration, and magnitude. For example, if we are observing children in the number of temper tantrums that they have per day, well, we can observe the frequency of those tantrums. We can observe how long each of those tantrums lasted, which will be duration. And we can observe how loud and violent each tantrum was, which would be magnitude. One procedure is referred to in observation as interval recording. And this involves dividing an observation period into equal blocks of short time intervals and recording whether the target behavior occurred during each interval. Another procedure is referred to as spot checking. And this is the less obtrusive and less reactive approach where the observer appears briefly and at intermittent times and records observations using a predetermined checklist. So this will be an example of an interval recording form. So we see here that we have 10 intervals. And so we're essentially checking off if we observe any of these behaviors during these particular intervals. So this is one way to go about directly observing behavior. And another approach will be spot checking. And this is less obtrusive because the person is not in the observational setting for a long period of time. They are there for a very short period of time, long enough to complete a checklist. And the observer typically pops into the observation setting at intermittent times. And so this will be what we call spot checking. And I couldn't find a checklist that was specific to social work practice. A lot of the spot check behavioral kinds of checklists were more in the field of occupational health and safety. But I was able to find this one, which is essentially what we're getting at here with this idea of spot checking, is that it's typically like a yes, no kind of response or category. The two categories here are either safe or at risk. So if we were to enter a particular observational setting, we're looking for these specific things here on the left, and we're just simply checking off, is it safe or is it at risk? Okay, so it's very quick. It's intended to be very quick, very unobtrusive, and the observer can enter and exit the observational setting at intermittent times so as to not be or to be as unobtrusive as possible. And then this idea of triangulation involves using more than one measurement instrument, source of data, or observer to assess the same target problem. And so triangulation, I know because a triangle has 3 points that we kind of think of triangulation as being at least 3 methods. However, by definition, this idea of triangulation is really at least if we have 2 methods or more. So at least 2. We don't necessarily need 3 in order to triangulate. We can triangulate with at least 2 methods or more. And this helps to corroborate results, as relying on one method alone makes results more vulnerable to issues of validity. So we always want to triangulate our measurement instruments, triangulate our sources of data, triangulate our observers. In whatever ways we can triangulate, we want to try to do that in order to be sure that the data that we are getting is most valid and accurate. And then in terms of using single case design and time series designs as a part of the evidence-based practice process, single case designs are recognized as the most rigorous and practical way that practitioners can implement the final step of the evidence-based practice process into their clinical practice with individual clients. And so I wanted to go back to the EBP process because I feel like it's been so long since we've talked about it. And so keeping in mind that step 6 in the process is where we actually evaluate the effectiveness of our intervention and provide feedback to our clients, to our supervisors, on the extent to which the intervention that was applied was indeed effective in achieving client outcomes. And so the single systems design can be integrated within the evidence-based practice process, and I'm going to show how we can go about doing that momentarily. But I thought that it was important to go back and talk about how this particular design can be integrated. And really any of these designs that we talked about can be integrated within the evidence-based practice process within step 6, but your text specifically brings back the discussion of evidence-based practice, the evidence-based practice process into this chapter on single case designs. So because the design requires only one case, there's no need for large samples or controls or comparison groups. Each experiment contains specific objectives and treatment goals that are applicable to each client as a part of practice. Taking repeated measures of changes in client outcomes provides a systematic and valid means of monitoring client progress toward obtaining treatment goals. So essentially what your text is getting at is the practicality of a single systems design in social work practice, and how we can go about really capitalizing and utilizing this design, given its feasibility and practicality in terms of only requiring one case, and not requiring the use of large samples or control groups, and then also being able to just focus on one client, and specifying some objectives and treatment goals, and utilizing a single case design in order to evaluate the outcome of those goals. And so in terms of steps in the EBP process, so here are the steps here as a reminder. And so when we're looking at single case designs, we're talking about how to integrate them into this last step, right? So we know that we go through this process of formulating a question, searching for evidence, critically appraising that evidence, determining which research supported intervention is most appropriate, and then applying the chosen intervention, and then finally providing evaluation and feedback. Well, when it comes to this last step, that's where we can integrate in this single systems design. And the way we would go about doing that is we want to make sure that we, prior to applying the chosen intervention, that we implement a baseline. Okay, so prior to applying that intervention, we can actually engage in step 6 before step 5, in that we want to be able to establish a baseline here, which is a part of step 6, right? So we want to be able to establish this baseline, then we can apply our chosen intervention, and then we can finally collect data during the intervention phase once we have introduced the intervention. So this is how we would go about integrating specifically an A-B single case design. Of course, it would look differently for other designs, but if we're talking about a basic A-B single case design, this is how we would go about integrating this into the EBP process. So if we can understand the basic design and how to go about implementing that, then we can then modify the EBP process in order to integrate other kinds of designs in as well. But at the very basic level, I just want you to understand how to go about implementing an A-B design into the process. And in terms of single case designs in social work, although this design is limited in its generalizability, as I mentioned before, the accumulation of single case evidence can advance the scientific basis needed to substantiate the effectiveness of an intervention program or agency. Although these designs provide a feasible and practical way for practitioners to, these designs provide a feasible and practical way for practitioners to engage in the evidence-based practice process, integrate research and practice, engage in practice-oriented research, and ultimately advance the empirical base of social work practice. So again, single case designs are only we're only dealing with one client in a single case design. However, it's really about the totality of the evidence and the accumulation of the evidence that we're able to glean from single case designs. And when we're able to replicate these designs, we're able to accumulate evidence for the effectiveness of a particular intervention. So these designs are very doable and practical for the practitioner, and it gives them an avenue or a way of contributing to the empirical base for social work practice. And so we looked at experimental or quasi-experimental designs previously, which was a group design. And so then we can then take that group design and if we want to look at or determine the extent to which an intervention that was effective for a group may be effective for an individual client, then we can simply move from an experimental or quasi-experimental design to a single case or individual design. So these designs can be used interchangeably because what may work for the group may or may not necessarily work for the individual client. So there are times in practice in which we may need to move in between these or we may need to move from a group design to a more of an individual design. And so we see here this example that we've been working with when we looked at chapter 11 and 12, which was more of a group-based design, right? And so this was for a group. So we have our intervention group and we have our control group, right? So we know that this is a true experimental design, which is a group-based design. But again, if we decide that, okay, we know that this particular intervention is effective for a group of clients, but is it effective for an individual client? Well, we don't know that, right? So then we could then pivot, right, from using the classic experimental design to using a single case or A/B design. Okay, so this is how we would move from a group design to an individual design to begin to ask the question of whether the same intervention that was effective for the group will also be effective for the individual. And we can simply draw on the same sample we use for our group design. We can pull out one single case from that we used in our in our group experimental design. We can pull one case from either our experimental or our control group, and we can implement a single case A/B design with that one client. Okay, so I just want you to understand how we can draw on each of these designs within practice. And then obstacles to implementing single case designs in social work agency contexts. So I always want you to understand the obstacles because there will be obstacles. These designs are great in theory, right? But when we really start to look at how to implement them within agency contexts, there are some very real obstacles that we need to be aware of. Because it can be difficult some of these designs can be difficult to implement, particularly within certain kinds of agency contexts or with certain types of target problems or with certain types of clients. And so some of the obstacles are with a single systems design in particular may be that client crises sometimes do not allow practitioners enough time to take repeated measures to establish a stable trend of baseline data before implementing the intervention. Also, heavy caseloads could reduce the amount of time practitioners have to plan or conduct repeated measures during any given phase of the process. Also, peers and supervisors may not recognize the value of evaluating one's own practice and may not support it. And then finally, clients may resent the extensive assessment procedures that are required for implementing a single systems or time series design. We know that both of these designs require the use of repeated measures. And so some clients may be resistant to that, right? But at least we know that we have the B or the B plus design or other alternatives that we can use in the event that we run into these kinds of obstacles. So we have a lot of options here. But it's important to understand what some of the obstacles are that we might face in the field so that we're prepared for them. Despite the obstacles, practitioners should strive to implement single case designs whenever possible. Many interventions remain untested and the evidence base for their use in practice is lacking. So the question is really not whether we can afford to do this, it's whether we can afford not to. And so we want to think about the questions, are we helping or harming clients? Are we wasting time on ineffectual services? Are we truly ameliorating human suffering? If we're not really evaluating our practice, are we really ameliorating human suffering? Are we wasting scarce resources that could be put to better use? Can we use our time and resources to implement alternative services that may be more effective? So engaging in this process of evidence-based practice and implementation of single systems designs can help us to answer some of these questions. Given our commitment to social welfare, our clients, given our commitment to the social welfare of our clients, implementing single case designs and research in general in practice really is an act of compassion, conscientiousness, and professionalism, which requires no aspiration to be a researcher or publish scientific findings. So, as I've been mentioning to you all, while it's certainly a noble thing to actually publish the research that we are conducting in our practice. In many instances, the research that we do in practice will never see the light of day, as I always say, and it's strictly for informational purposes, and that's okay. And so our goal is really to be compassionate towards our clients and to be conscientious and professional. It's not necessarily to publish. Okay, and that's totally fine. And so I think that this is important to keep in mind. And finally, with regard to critiquing single case designs, here's a list of questions that I am offering to you with regard to some things that we should be thinking about when we look at single case designs, and some questions that we should be asking when we look at critiquing and assessing these kinds of research designs. As we know, and as we've been talking about, the questions that we ask with regard to critiquing research really depends on the features of the design itself. And so, as you've seen in other videos, the set of questions that are asked are very different, and they change from design to design. So here are another set of questions that you can ask and think about as you look at single case designs as well. And then here's an exercise, once again, for single case designs. Very similar to previous exercises in terms of having you to think about a client in your field placement, a problem or outcome that you'd like to improve with that client, an intervention that you're currently using or that you think you may use. And then from there, designing a single case design experiment that employs one of the research designs that you've learned about in this lecture, and then also thinking about what the strengths and weaknesses are of that design. And then here, as always, is my contact information. I hope this has been helpful and useful to you, and I look forward to seeing you in the next class.